This week on the BackTable podcast.
Don't choose a fellowship based on location. It's 1 year or 2 years. I've heard people say, I want to go to somewhere cool for a year. It doesn't matter. It's a year. That year is so intense. It is so full of learning. It does not matter where you go geographically for that year. I guess unless you have a really specific situation, family situation or something. But otherwise, you are not going to be getting out and enjoying that city as much as you think.
This is George Koch from The Ohio State University, and I'm really excited to introduce Dr. Rachel Mann this evening to talk a little bit about the past, present, and future of reconstructive urology on BackTable Urology. Dr. Mann is an assistant professor of urology at the University of Minnesota in Minneapolis. She earned her bachelor degree from Goucher College before earning her medical degree at the University of Michigan, completed residency at the University of Minnesota before fellowship in reconstructive urologic surgery at Lahey Hospitals and Medical Center, and finally returned to the University of Minnesota as faculty. Thank you so much for being here, Dr. Mann. I really appreciate your time.
Thank you so much. And George, you and I are the same year. It's kind of fun to be interviewed by one of my peers. So this should be great. Thanks so much for having me.
Yeah, absolutely. Absolutely. So Rachel, I'm super excited to talk to you about this topic today, past, present, and future of reconstructive urology. Could you start off just by telling everyone a little bit more about your background, what drew you to reconstructive urology in the first place even?
Sure. So when I was in medical school, I thought that I was going to be a plastic surgeon. I had some early exposure to plastic surgery. I did some shadowing in undergrad. I thought it was really neat. I was a creative type always. I was a theater kid, and I did a lot of performing arts stuff, a lot of creative hobbies, things like that. And in medical school, this is a true story. I loved plastic surgery, but I hated hand surgery. Like, I would faint. I would hit the deck if I saw a trigger finger release. Like, something about hand surgery, it freaked me out. And I talked to one of my mentors, and she was like, oh, no, that's a pretty big component of plastic surgery. So I said, shoot, I have to change course. And I stumbled on urology, as most medical students do. I feel like they get accidentally placed in this rotation and they fall in love with it. My story's no different. And as soon as I rotated on urology, I realized that that's what I wanted to do. Reconstructive urology was not initially on my radar. If you asked me what I wanted to go into when I matched into residency, I would have told you infertility andrology. But I happened to match a program with a very strong reconstructive program, University of Minnesota. Sean Elliott is there, one of the big leaders in reconstructive urology nationally. And I had really early exposure to recon. As a PGY2, I was routinely doing reconstructive cases. There was actually, bizarrely, a time in my residency where I had logged more vaginoplasties on my case log than RALPs. So this really helped to shape my interest early on, and I was excited about it. So although Minnesota has a really strong reconstructive fellowship, my mentors, of course, encouraged me to go learn some new skills at a different institution, and that was absolutely the right decision for me. So I went to Lahey. I trained under Alex Vani, and kind of the rest is history. That's my story of how I got into reconstructive urology. But I really like the breadth. I really like the fact that it was urology, but a little bit of plastic surgery, sort of GU plastics, and I had a chance to be creative.
We actually had a medical student with me in Collect today, and she asked me about urology and about reconstructive urology, and I feel like everyone has that story of finding urology late, and then when she asked about reconstructive urology, it's so hard to kind of nail down what exactly that is. And it made me think about, our episode coming up tonight. You mentioned two different programs, which I think is a very cool part of your training. I trained under a reconstructive urologist, a couple of them at Vanderbilt, and then went to the University of Washington, and now both those places have fellowships as well. So I really value kind of looking at things from two different ways. But one of my big mentors from residency did the same fellowship that I did at the University of Washington, Niels Johnson. So I was hoping you could talk a little bit about what it's like to train, in two different reconstructive programs and how that, changes or helps you evolve maybe the way that you think about the field?
Yeah, that's a great question. And you similarly came from two, reconstructive powerhouse programs. It's funny, Minnesota has kind of, I should actually use past tense. Minnesota had kind of a funny reconstructive practice up until recently when I joined back, and we could talk about that in a little bit. But the mainstay of reconstruction at Minnesota was transitional care. So Dr. Elliott has built this huge transitional urology program. The majority of his practice, aside from bread and butter, urethroplasties, perineal surgeries, he certainly is a master at all of that, but he did major intra-abdominal reconstruction, augments, cath channels, bladder reconstruction, diversions for radiation injury, things like that. So big open belly surgeries. And then his junior partner, who is now my partner, Joe Pariser, opened our transgender program. So we were really heavy on intra-abdominal recon, really heavy on transgender, had a good breadth of robotic upper trap recon, but didn't necessarily have the high volume traditional recon that you would think of, prosthetics, tons and tons of urethroplasties every day. And that's what I gained from training with Dr. Vani. Anything below the belt, he can handle. This guy's a genius, urethroplasties, fistulas, Peyronie's disease, prosthetics, buried penis repairs. Anything below the belt, this guy's got it. And so that's really what I gained from my training at Leahy and was then able to bring back to my job once I rejoined the faculty at University of Minnesota. So now, in present tense, we have kind of all three of us doing a little bit different subset of reconstructive urology, but we still do have overlap between the three of us for sure.
Yeah, I love that. And I think it was obviously GERS is a match, but it sounded like a match made in heaven as far as, the training that you had and then the kind of fellowship training that you augmented that with. It sounds perfect.
Totally. And, something also that I find great about recon is that everybody has their own funny little personalities too. We're all kind of creative types. We all have our own way of doing things. My two biggest mentors, Sean Elliott and Alex Vani, really have, I think, the same philosophy. They think the same about things, patient-centered approaches, and they want to train the best surgeons. But their specific approaches couldn't be more different. And I enjoy both of them. And it's funny even going to these conferences with the leaders in reconstructive urology. We're all a little bit weird in our own way, just creative thinking. And that's what makes our field so special, I think. And I don't think being weird is a bad thing. But, I certainly got two different perspectives, two different teaching styles. Dr. Elliott, I would characterize as kind of that subtle genius. Like he's mentally always 2 steps ahead of you. I found him quite intimidating in residency for no other reason other than I just respected him so much. And he was so technically excellent and smart. And he really just didn't want to say anything stupid. And he was more of just kind of a quiet, subtle leader. And in fellowship, Dr. Vani brought the intensity from day one, and his style was totally different. And he was all about efficiency and energy and time management and how to set up a case while teaching. He's kind of a cortisol junkie, like thrived on this busy schedule, sort of like me. That's kind of how I operate too. So it was really beneficial for me to see these two totally different styles and take aspects from both of them into my own life and my own practice.
I can absolutely see, I know them both kind of professionally, not as a mentor-mentee relationship, but I can totally see the personalities that you're talking about.
Yeah.
Both, leaders in their own way with very kind of unique ways to go about it.
Absolutely.
And there's so many different ways that people in the reconstructive community and the GERS community, approach problems and approach questions. I love, we just had our GERS conference in Minneapolis a couple weeks ago,
Yeah.
and even just talking to people, getting to hear them present about things. I just love the kind of the different ways people come at the problem and how strongly they feel about it too,
Yeah.
which I think makes for great debate.
It does. It does. It's great. I'm sure you had similar experiences in your training and training with, a bunch of different people. It's really fun. And then at the end of the day, you can pick and choose what style fits you best, and you learn great lessons from everybody that way.
Yeah, no, it was funny training under someone who had done the fellowship that I did. I think Niels was 5 years before me at the University of Washington, but the way he did things was very quintessential University of Washington, except for key things that he had changed. And there was no guidebook on, what I should do and shouldn't do once I got from one place to the other. And I specifically remember Dr. Wessels looking at me in the middle of a case and being like, "Where did you learn that from?" And I was like, "I learned it from Niels, I thought learned it from you."
Busted.
Yeah. There were a couple things that I think I was not supposed to let people know that he had changed. But yeah, the learning in the different schools of Reconstruction, was just so beneficial and so interesting and thought provoking. Forces you not only to learn the way that people want you to do it while you're learning, but then to kind of rethink it when you become an attending and they say, "Well, what drapes do you want?" It's, "Well, I used one drape at one place and one drape at the other place. What's going to be my thing?"
Isn't it funny? Yeah.
Oh yeah.
Yeah.
So having trained at multiple reconstructive programs, I'd love your take kind of to get back to our big question. What exactly is reconstructive urology?
Man, this is a great question. So I think the definition of reconstructive urology keeps evolving. It's a really loaded question. And the field right now encompasses so many different subspecialties: transgender, trauma, male reconstruction, urethral reconstruction, robotic upper tract, transitional care, neurogenic bladder. What am I missing? I mean, I can't even sit here and think of all of them. But there's so much. And it's funny because when you're looking at fellowships, each different program has different aspects that they're strong in and that they're training you. And so it just keeps getting more and more broad. I mean, there's been this giant boom in technology. The single port robot has, opened up so much more with upper tract recon. And people are getting more bold. They're getting more creative. They're, using their other skills that they've learned, whether it's robotics or just from, I don't know, watching other people, watching plastic surgeons. They're taking these skills and they're being creative. They're coming up with new surgeries. Just look at what we've done with transgender care. It's fascinating. So I think if you get a bunch of creative surgeons together, the sky's the limit, really. And I'm really excited to see sort of what the future holds for reconstructive urology, but it's really broad. And just sort of being the fixer of problems when other people call you, like other surgeons specifically, like, "Hey, I'm in the operating room. I see a tubular structure. I think it's the ureter." Or, "Hey, I got into the bladder." Or kind of, I don't want to say we're we all have hero complexes or anything like that, but it's kind of fun to be that person who,
Yeah.
you can fix a problem right in the moment. Or even another urologist has a disaster with a stone case, so it was supposed to be routine, a ureter gets avulsed or something like that, or a gynecologist, a patient develops a fistula. It's really great to be that person who can take what would have been a disastrous complication and kind of save a day.
Yeah, I couldn't agree with you more. I don't know whether it's batting cleanup or pinch hitting. I don't know what the baseball metaphor is, but I love getting called into another operating room and just stage an injury on the fly.
Yeah.
Try to do your best for the patient. Think about what you can do, what you can't do, what you've done before, what worked, what didn't, what you've done that's close.
Yeah.
and just trying to help. I love being that person. And I don't know about you, but I feel like for the consult service, a lot of times I'm the person who they come to and they're like, "We've got this thing, the person on call wanted to just run it by you real quick." I love that part of my job.
This weird problem that no one's ever heard of before that, exactly.
Yeah, I think trying to list what surgeries, I was going to ask you what surgeries fall under this umbrella. I feel like it's not fair. It's everything. And you're right, really, it's stuff that we've adapted from the MIS folks, from the plastic surgeons, from other urologists. What's included in reconstructive urology is just so vast. Could you touch a little bit about how you've seen that change over time and how you've heard about it changing over time? We're young in our careers, but I agree with you. Even I feel like 10, 15 years ago, reconstructive urology was something a little bit more specific and defined.
Yeah.
So can you talk about the change a little bit?
Yeah. And I think the mainstay of reconstruction has always been the same, restoring function. I think the goal of reconstructive urology has always been the same, but we didn't necessarily have all the tools that we have now to accomplish those things. But I think bread and butter used to be tons of urethroplasties. It used to be fistulas, it used to be a lot of open surgery. I'd even throw prosthetics in there, bladder reconstruction for sure, learning how to repair injuries, trauma. Over the last, at least 10 years, the huge boom in robotic reconstruction has really taken off. Transgender has really taken off. And we've come so far in terms of different techniques for, cancer survivorship, radiation injuries, ureter reconstruction, be it open or robot, diversions. We've come a long way there. And then, of course, men's health, Peyronie's disease. We've gotten better at prosthetics. Prosthetics are always around, but now we've been able to, use grafting material. We have different ways of doing implants, making them look better. I think we've really been able to hone all those skills where, before maybe reconstructive urologists could fix a urethra or could put in a prosthetic, but now, everything is so nuanced and there's all these technical variations to make surgeries not just, pretty good, but perfect, which has really been fun to see.
How do you think that's changed the training to be reconstructive urologists? One of the big, things that I feel like we talk about in a lot of meetings is over the past 10 or 15 years, we've gone from about 10 fellowships to about 30 fellowships. So, talk a little bit, maybe if you could, about what the advances mean for training programs.
I think it really means that the applicant or the fellow can choose what area they want to focus on. I know that might be hard, and it probably depends on if you went to a recon heavy residency. You may not know what type of recon you're interested in, but I think we're really getting away. There are very few programs that have absolutely every area of recon represented. There are still a few, but I think those broad programs, you're going to see those dwindle over time as more fellowships open up. But applicants really have the ability to super subspecialize, and that's great. I think the elephant in the room is the job market, especially the academic job market is tough. But I also don't think that there's anything wrong with doing a fellowship and going into private practice and doing great surgery there and doing some general urology, or going to a rural area and doing mostly general urology, but having the skills to fix these complex problems. As well as I do, we both practice in the Midwest, and we have giant catchment areas, and I have patients all the time coming from, North Dakota, 10 hours away, the Canadian border. There's really a need for people who do this work. So I think it's going to be a mindset shift as more fellowships develop and the interest increases. I think it's great. I think the fact that we have so much interest in our field is a good thing. I know that's controversial. Like, is our field growing too rapidly? But it's not a club. This isn't an exclusive club. You're allowed to like this stuff. Yeah. And we should encourage people to learn how to do this stuff, even if you don't go into academics. I think that's really important, because at some point, there's not going to be space for everybody to go into academics. I think it's still valuable.
Yeah, no, I couldn't agree more. I know that you have gotten the referral from a patient who's coming from a couple hours away and has had a urethral dilation 10 times.
Oh, yeah.
Yeah. And the guidelines, are pretty clear on those patients. Oftentimes are years beyond where they should have probably been sent for urethral reconstruction, but there's just no one who does it. So, I couldn't agree more that I think that it's great for reconstructive urologists to go into private practice, and that may be the kind of the next place to fill out the field, and internationally as well.
Absolutely.
But there's a lot of recon to go around. I'm as a young attending at a very young reconstruction program, I certainly feel like, every time you bring in someone who can do something, tons of patients show up that have that problem that just didn't have someone to address it before.
They do.
I think that the patients are certainly out there and need us for sure.
They do. And I have to say, I think I had a little bit of a mindset shift about this going from probably residency to fellowship to attendinghood. When I was, I guess, a resident applying to fellowship, I was sort of, I guess, thinking about, and maybe that was, the trauma from residency, but
You
thinking
have to
about,
when you're choosing your fellowship.
I want to do cool surgery and I want to have a good
Mhm.
job that pays well and live in a good city. And this is going to sound cliche, but I think as I moved along in my training, my focus has really shifted from like worrying less about me and but worrying about the patients. I mean, and as you see these people walk into your clinic, it really becomes apparent that there's such a need. And, at the end of the day, all of us as reconstructive urologists should be thinking about what's best for the global population and what's best for the patients out there. And certainly there are not enough of us.
Yeah. I mean, I truly think that the market decides a little bit.
Yeah.
And this one thing that I really didn't expect coming out of fellowship was that my fellowship training, obviously it hugely informs what I can do as a reconstructive urologist, but it really doesn't dictate the kind of patients that I see or the cases that I book. Like they do, and if I need to do something that, I maybe didn't do a lot of in fellowship, but I did similar things and I did lots of robotics during residency. I think those things, to your point earlier, you put the things together that you have to solve the problem for the patients.
Yeah.
But they really decide what you do.
Yeah, they do. They do. And that's why this field is so fun. Again, it all goes back to creativity, and it's not at all algorithmic, really. I mean, patients show up and you have to think about what the problem is and what tests do you want to order to give them the best outcome. And sometimes that's not even the same for every individual problem. So I don't know. I like scratching that area of my brain.
One thing that I would love to talk about, and it's something I don't really know where I fall yet, but I have been thinking a lot about it recently, is with this big need for reconstructive urologists in areas that are in maybe non-academic settings. I've really been trying to think about what kind of cases, as I'm an early attending teaching residents, what kind of cases I think my residents should be able to do by the time they graduate. We've talked about recon being so vast and kind of covering so much and covering new disease states and new surgeries all the time. Do you think that residents see and kind of learn enough during residency to do some of the bread and butter cases?
I think it totally depends on your residency. I mean, some residencies don't have really any recon. Some have a ton. So it totally depends on your residency. It depends probably on the resident, how motivated you were to go to those cases. I think the bottom line is you have to be good at them, because nothing is worse than going into practice and botching a recon case and then making that second redo case really bad for someone who's good at it. So I would say if you can go out after residency and do a really good 2-centimeter dorsal buccal urethroplasty, it has to be really good, but maybe you could do it. Or if you could do an AUS or a penile implant, if you've seen enough of them to walk out of there and say, I can confidently give this patient a really good surgery, then yes. But you also have to have the tools to be able to pivot, because as you and I know, urethroplasties can go south like 1-2 turkey. You have to be prepared. If approach A doesn't work, you have to have approach B in your pocket. And I think that's what fellowship gives you that residency sometimes doesn't. Even with implants, do you know how to fix an SST deformity? What if you have crossover? What if you have perforation? You have to be able to know how to manage those issues too. So you have to know how to manage your complications, and you have to be good at these surgeries. I think it's a little bit easier, maybe this is going to be a stupid answer, but I think it's a little bit easier to do some of the robotics cases well, because a lot of residents have spent a lot of time on the robot doing kidney work and prostate. So, a simple reimplant or a pyeloplasty or something like that. That's a little bit different. There's, of course, still things that can go awry in those cases. There's no question. But I think a lot of residents would say they're very comfortable on the robot doing those sorts of cases. So, but you just have to be good at it, and you have to know some backup plans and troubleshooting and how to manage complications.
Yeah. And maybe, as we talk about different fellowships and thus different residencies have kind of different areas of focus, maybe a resident from Leahy is ready to do perineal surgery, whereas a resident from Minnesota is ready to do congenitalism and abdominal work, and a resident from University of Washington is ready to take trauma call confidently. Maybe it's not a question of bread and butter cases,
Exactly.
but similar to fellowship, it's a question of you should be doing what you're trained to do well.
Yeah, exactly. I totally agree. I do think I will say with the caveat that there are some genius minds out there who, I'm going to use Li Zhao as an example of this. The godfather of robotic reconstruction, trained at a totally non-robotics fellowship. There are exceptions to this rule. And without creativity, our field does not move forward. So
Absolutely. Yeah, Dr. Kulkarni, when I visited him for the AUA exchange, used to say, if everyone follows the guidelines, who will invent?
Yeah, exactly.
Which I really liked.
That's a really good.
Yeah, it made it in the notebook written down somewhere.
For sure.
Another loaded question. This is like the loaded question section.
Okay.
So if we keep talking about, the subspecialty is expanding, we're getting broader, we're getting deeper, are we a long enough fellowship?
Oof. Well, I happen to think so. Oh boy. I think so. And you can answer this too. I think for my fellowship, I felt very good after a year. I think it probably depends on the fellowship. It depends on the volume. I never met a person higher volume than Dr. Vani. My goodness, his days were just completely packed to the brim. Please, less surgery. But no, I'm just kidding. So I think it depends on the place you go. I think program specific is probably the right answer. I think if we moved to saying everybody had to do a 2-year fellowship, I think we'd lose a lot of people because we're tired after residency. We're tired.
Yeah. No, I think I fall in the same category of program specific, resident goal specific. I think that I similarly agree with you. I operated a lot during fellowship and felt very comfortable coming out of fellowship. And I think, the market will decide. Again, residents right now a lot of them are going into reconstruction. That's why we've grown. The kind of bottleneck that we're worried about is on the top end. It's the job market. It's not the training bottom end. Like, people want to do fellowship.
They do.
So I think that that they're kind of telling us that unlike some different subspecialties that have 2-year fellowships, we're like hot and growing. So maybe the market has decided.
Yeah, hot and growing. I like that. That should be the new tagline. GERS, hot and growing.
I like it. It would look good on a t-shirt.
Yeah, it would. We've had several fellows at the University of Minnesota who've done a fellowship previously. The fellow we just graduated, Brian Chow, he did a robotics fellowship before doing his reconstructive fellowship. And we've had people do peds before their fellowship with us. So it's, there's going to be people out there who want to do that. And I think that's great. But just like you said, program specific.
Absolutely. And I know that there are folks who, for the programs that have research years, are super excited to get a second degree or do extra research and kind of like really beef up those research jobs.
Yeah.
He was an oncology fellow, but one of my really good friends from residency and he graduated from Memorial after an oncology fellowship. We were recently talking about a study that was in the Journal of Urology, and midway talking through this study, I was like, we used to have these conversations and I felt like we were kind of on the same wavelength, and his research chops are just way above mine now. And I think that some, there are programs that provide that and people who want it. But I agree, it's probably more of a program specific than a GERS wide initiative, I think.
For sure.
Which brings us to our last loaded question of the section. So subspecialty, a couple that I quickly wrote down were gender, robotics, trauma, congenitalism. I think that the fellowships kind of have naturally shifted to having, each has their own identity, each has their own, flair, if you will. Is that the way it should be with all of us kind of earning the same certificate? Or do you think we should be breaking and subdividing more formally? Any thoughts?
The one aspect that I wonder about might be transgender. That's coming from a place of just believing that nobody should really dabble in trans. I think there are a lot of programs that have a little bit of trans and a lot of other. And I don't know if fellows coming out of that program, if they've done a little bit of trans, would feel qualified or would be qualified to deliver excellent care in that realm. So I wonder if trans should be its own separate match or fellowship, since people who really want to devote their life and career to transgender surgery, if they should go to a program that's almost exclusively that. That being said, the leaders in the transgender field, they did not go to transgender fellowships. There was no transgender fellowships. My partner, Joe Pariser, he did Sean Elliott's fellowship, which was mostly focused on transitional urology. So not to say you can't do excellent surgery if you didn't do a trans fellowship, but I think there are so many out there that's something that in the future we could maybe try to think about. And I don't feel 100% strongly. I just kind of bring that up for the sake of discussion. But in terms of the others, I think staying as one single fellowship makes sense. And then, if you were a resident who came from a really strong robotics residency and you went to a fellowship that had a little bit of robotics, but a lot of perineal surgery, a lot of open abdominal surgery, I think that kind of makes sense to tailor your fellowship either based on what you think you could use a little bit more of or based on what you want your future career to look like and your favorite aspects. So I think it's fine the way it is.
Yeah, I think I land there as well. Gender, I think, is the one that kind of always gets brought out because I think there are just so many aspects to gender care that are different than typical reconstructive surgery in that, you have to know your WPATH criteria, you have to know your endocrine therapies. I think that there's the non-surgical is just as important as the surgical, and it takes a lot of nuanced knowledge. So I agree with you, and I think that's the one that typically gets talked about at meetings if we were to have kind of further subspecialization. But I agree with you that the meetings are more fun when you hear about everybody's stuff.
Yeah.
And you get ideas from one place and you integrate it to another. One disease state, you integrate that to a patient that may have a totally different problem, but you're like, I was at GERS, I heard about this, I think it'll work for that patient. So I think that it does keep it kind of fun and spicy as opposed to making it more algorithmic, I guess. Okay, we've touched on it a little bit, but more formally, what do you think the future of reconstructive urology looks like? We've done past, we've done present. What's in reconstruction's future?
I like this question. I think the future is bright for reconstructive urology. I think the fellowships are going to become even more competitive as our best kept secret of urology makes its way out there. Why wouldn't it? I think there's huge opportunity for research in recon. Turns has been very inspiring, our biggest research group to date. They've come out with a lot of great papers. They have their own database. I would like to see more of that. Something unfair about turns, maybe this is controversial, is that they're all experts. They're all masters. These are the best outcomes. And that's true. And I think they're representing the ideal, but I don't know if they're representing the reality of most reconstructive urologists. And I would even include non-reconstructive urologists. So people who do prosthetics, who do urethroplasties, who treat Peyronie's disease, who are not, necessarily GERS trained. I want some more data looking at everybody, all comers, all surgeons. What do these results look like? And I think Turns has really paved the way to create some sort of database. Even if it was GERS, that would be, a good starting point. But getting everybody's data together, looking at outcomes, I think there's definitely room for clinical trials, looking at different techniques for solving different problems. We talk about Optilume. At least I talk about Optilume a lot. Sean Elliott was one of the leaders in these clinical trials and is on many of the papers. And that was something huge that came out of reconstructive urology. And I think looking at new technologies, new drugs, Mayo Clinic has their RD-180, the endoscopic urethroplasty device. That's really neat. People are really doing cool things with technology. And I think that's just going to take off. Let's see, what else for the field? I think training folks to bring skills internationally is really important. I think there's a huge need for reconstructive urology in countries that are not the United States. GERS has several fellowships that are international, which I think is excellent, and I hope those expand. What do you think? I'll turn the question back around on my interviewer. What kinds of things do you think?
No, I love it. And I really loved some of the examples that you cited because I think it kind of gives us a little bit of a roadmap for the future. Optilume, they've been doing angioplasty like that for a long time. Like, well, I love that that someone was like, we should be using that in the urethra. Like, it's a tube. Maybe it can benefit from the same sort of thought. The RD-180. You talk about Nick Warner, like that. He customized the sheath, obviously, with industry to be able to fit in the urethra, but that suture device was on the shelf. I think that looking to other specialties and kind of looking at what we can adapt,
Totally.
I think is just fascinating. And I think the smart people in our field really look for inspiration. I remember, we spoke about Lee Zhao earlier. I remember him talking maybe a couple years ago about going to conferences of other specialties to just see what they were doing and try to get some advice and some thought on things that other specialties might see as routine where no one had just applied it to urology yet. I think that's a great potential avenue. I think from a research standpoint, I agree with you. I also think that kind of looking towards the research enterprises that have been really successful in urology, like what are oncologists doing? How do they do it? And how can we replicate it for urologic disease states? I think is really, really fascinating. And then could not agree with you more internationally. I think that there's a huge need for reconstructive urologists everywhere, and trying to figure out how to train folks for international work, I think is hugely important. And how to integrate, one thing that we do so much of in the US now is robotics. How do you integrate training someone who may go into a practice environment that doesn't have some of the resources that we have? I think is really interesting as well, and something that we still need to figure out, because you're right, we need to be training reconstructive urologists for everywhere. And I think the future is figuring out how to train and capacity build. Jane Kurtzman at Utah has done some of that with her new initiative, GU Impacts. IVU Med has been, training surgeons, and, I know that they've got teaching as part of their, like core philosophy. I can't remember. They have like a catchphrase and I can't remember, but, I think that figuring out how to teach folks to go internationally and decrease the disease burden way outside of Ohio and way outside of Minnesota is going to be just as important as figuring out what we're doing locally.
Yeah, totally agree.
So one final thought, or one final little section. I thought it'd be really fun to do like a rapid fire advice session. I think we've talked about you've got, I think, a really nice breadth of experience. I know you work with the residents and fellows committee. I'm sure you are giving tons of advice and mentorship there. So I really wanted to kind of leverage that and do some rapid fire advice. So for residents interested in reconstructive urology, what advice would you give them as they're trying to choose between such variable fellowship options?
Great question. Okay. I would say think about what aspects of reconstructive urology you want to do in the future. So keep that first and foremost in the back of your mind. What do you envision yourself doing? / what do you like doing? The other way you could think about it is, what are you deficient in? I would say probably not a lot of residents go to fellowship to do a skill that they haven't seen before. You might. And then I would say you have to vibe with your fellowship mentor. That's key. I think these interviews, most of them are virtual right now, but you do get a sense of, can you spend a whole year with this person? And fellowship's a lot different than residency. There's nowhere to hide in fellowship. You're sitting knee to knee with this person every single day. You want to feel comfortable with them. You want to feel like they're a good personality match for you. I certainly couldn't have been happier with my choice of fellowship, and we got along great. And Dr. Vani, he's on speed dial. I text them once a week about something. It's fantastic. But during fellowship, you really have the opportunity to make a lifelong mentor, somebody who's going to be there for you for the rest of your career. And that sounds like a lot of pressure, kind of is, but it's sort of true. It's sort of true. And then there are a lot of new fellowships opening up, which is great. I would also say, look at where the fellows have gone from the programs and what do you want to do? Again, it's totally reasonable to do a fellowship and want to go into private practice or want to go into rural urology and take some of these skills back with you. That is so reasonable. But take a look at the kind of pedigree of where people have gone from that fellowship, because I would say where the fellows have gone, maybe this is kind of hidden curriculum, but may or may not be sort of the expectation of you. Does the fellowship really value, producing academic reconstructive urologists, or is that less important to the fellowship itself? And it might be a good question for fellows who have graduated from that program.
Yeah, I couldn't agree more. And I think the big thing that I would stress, both as people are looking for fellowships and also as you're kind of settling into where you're going to go for fellowship, like post-match, I'm going to a place and I'm settling into the idea of being that fellow. I think that it's really important that 2 out of the 3 things that you mentioned were not case mix. We're not skill specific. Vibing and career plans and trajectory, I think, are 2 things that, you can really take regardless of the case mix. And again, I do think that your patients, the patients that show up to your clinic are really going to decide what surgery that you do. Yeah. In a lot of cases, you should only be doing things that you've, as you said before, can be great at.
Yeah.
But, you may have come from a fellowship that is heavy perineal and you go to a place and you have to use more of your robotic skills. And I think that getting comfortable with the fact that you don't have to have the same case mix as your fellowship director is another big thing that I think is really important. You want to take those skills, but not necessarily feel like you have to have, the type of manicured, exactly what your fellowship director wants to see practice in the future, I think is something that it took me a little bit of time to get comfortable with when I started my job, actually.
Yeah. Is your practice different from what you trained in fellowships? I imagine it would be.
Yeah. We are a level 1 trauma center, but we don't see the nearly the level of trauma. Yeah, not at all. But those skills translate. They really do. I think a great example is we're a big sarcoma center, and not at all the same thing as trauma. Completely different disease process, except for the fact that sarcomas happen to happen in the retroperitoneum. They all get done with big open incisions, and they often involve the ureter. So, like at Harborview, I was going in to reimplant ureters because they got shot or blown up. And here I get called in to put the ureter back onto the bladder because they needed the last distal couple centimeters because there was a sarcoma on it.
It's funny.
But it's it's a very similar kind of it's the same procedure. Not at all what I would have thought that my training was going to I did not look for a sarcoma center as I was coming out of a trauma fellowship.
Yeah.
And I think that, your patients decide what you do, but you can use those skills in any way,
That's a really good example. Yeah. I would say 15 to 20% of my practice right now is robotic upper tract. And my fellowship was 5% or less. I just chose a fellowship that was not heavy on robotics, but it's pretty interesting.
Yeah, and that's I hope GERS would be proud of us saying this, but I think that's kind of the special thing about GERS is then you learn a way to think and you learn skills that you can adapt both of those things you can adapt to the problems in front of you.
Exactly.
Yeah. Okay. that wasn't quite rapid fire, but that's
Yeah,
probably
yeah.
my fault. Next one, how about incoming fellows? What would you recommend for them to have a successful
Oh, wait,
fellowship?
can I give one more piece of advice for the residents?
Absolutely.
Sorry, not rapid fire. One more piece of advice for residents. Don't choose a fellowship based on location. It's 1 year or 2 years. I've heard people say, I want to go to somewhere cool for a year. It doesn't matter. It's a year. That year is so intense. It is so full of learning. It does not matter where you go geographically for that year. I guess unless you have a really specific situation, family situation or something. But otherwise, you are not going to be getting out and enjoying that city as much as you think.
No, couldn't agree more. I don't want to judge anyone's family situation.
Right.
I agree with you on that. But I will say that you can't go anywhere for a year. I did long distance with my wife for 3 hours time difference, long distance for a year. And it was tougher than residency where we were about an hour apart, but you can do anything for a year, and the training that you're going to get is intense, and you get this opportunity to kind of see in somebody's mind and be their best friend for a year. And I agree with you. I think that if it was the right place to go, do it in Antarctica.
Yep. I had a whole baby during my fellowship here in a place where I had no family, and that was wild. But you know what? You just do it.
Absolutely. Okay, so back to our fellows coming in, what would you recommend for them to have a successful fellowship?
You got to grind. You have to just be in the mindset that this is your final opportunity to be taught anything. Because once you leave, there's nobody watching you anymore. And it's a different grind from residency. It's a great grind. It's exactly what you want to do. Residency, the slog of getting numbers and managing, floor pages, and there's way less of that. This is like, in a way, it's almost like a pressure-free year. And what I mean by that is that these aren't really your patients really yet. There's still someone over you who is so generously letting you learn from them, but you're not part of this resident team having to do the grind of being resident. You're not yet a staff, but you're kind of acting as one. And it's such a gift. It's really the most incredible year, and just soak all of it in. Take advantage of it. Really fully immerse yourself and keep notes. And I'm talking about take notes on everything. Take notes on the drapes, like you mentioned, the setup. Pay attention to how your mentor is teaching the residents, how they teach the senior residents, how they teach the junior residents, what parts of the case are they letting people do, how are they delegating. If you're going to be teaching residents in your new job, that's stuff I didn't pay attention to in residency. I was just trying to focus on the steps of the case and the stitches to throw, but that'll all come. Focus on really the management of the day, and be a doer, be a yes person, offer to stay late and help, offer to help other surgeons if they have a recon case come in. Be available, be available if you can on weekends for if general urology is taking call. Hey, if a recon case comes in, I'm here, call me. Just take full advantage of it, because you have responsibility in fellowship, but you don't have that kind of responsibility like you have when you leave those doors. So just take full advantage.
Yeah, and you never get it back. And you could say that about all of residency, and it's true. And I think that I really try to focus on this when I talk to our residents at Ohio State, that you don't get this time back. But once you're in fellowship, not only do you not get that time back, but it is all what you wanted. Like, it is all what you're going to do in practice. Get this opportunity to just learn, almost unencumbered, exactly what you're going to be doing. So valuable. And I'm getting goosebumps just like thinking about my year. Yeah.
Yeah.
But you learn so much, and it's
the good old days.
Yeah. How about graduating fellows? What advice would you give to a new faculty as they're looking towards early career? And this one is, we are right in the midst of it. But maybe starting a practice is a more fair way to say it. We've both been in practice for a little over a year. Like, we've started practices. What advice would you give them?
First year's a trip. I mean, this is someone, I think I wasn't prepared for the level of anxiety I was going to feel about everything. I think it took me doing a specific case maybe 3 times before I didn't have intense anxiety about something. And these are mostly irrational fears. I remember the first time I put an implant in, an IPP, I laid awake at night and I thought to myself, what if you put that reservoir in the bladder? I didn't. Have I ever done that? What are you talking about? But like you freak yourself out. I mean, there's no one watching you. There's learners learning from you. You're worried about when you first start, judgment from the OR staff. I don't want these scrub techs to think I'm a hack. I want, it's crazy. Even dealing with in-basket messages. What surprised me is, and maybe this is just me, maybe maybe this is not a universal experience, but it surprised me how few patients get by with a surgery without needing something. Whether it's a MyChart message of, does this wound look right? I'm having a little more pain than I thought. Like, I guess, especially in residency, I didn't know that these little things were coming up, and you get more used to them.
You're like, I thought it went well.
Exactly. You had a perfect outcome. What do you mean? So I would say to quell my anxiety, I do a lot of same day visits. Like I'm always available to my patients. I say, if I've operated on you and you have a concern, you can see me same day or next day, like most always, unless I'm out of town. And then you can see a partner of mine. But I think being available to your patients, if you have somebody you're particularly worried about, calling them. If you have a complication, running toward that complication. I can't stress this enough. I'll tell you a story. I did a vasectomy. I do vasectomies for fun. I like vasectomies.
Hey, if you like it.
Yeah, I did a vasectomy, and I was doing it in clinic. And I spread my little Jake and I hit what was probably the vasal artery, like right in front of my face. And it was pulsating. And then the patient coughed and his cord retracted and the artery disappeared. And I was in clinic and I was like sweating and I watched this hematoma form in front of my eyeballs. This is the first year of practice. And I knew immediately that I needed to take the patient to the operating room, that my Pen Bovie and Adson were not going to cut it.
Yeah.
And it took me a long time to get over that. By the way, I took the patient to the operating room. It was very nice. It was a 5-second case. I left a little drain. He was totally fine and he was not mad. But these things, that's just a tiny example. And I'm sure much worse things will happen. But I was sitting on the floor of my shower, I should never have done this job. And it's very easy to just go down the rabbit hole this first year of practice, and a lot of, self-doubt of even these little things. Now it sounds so silly, but it's true. So give yourself grace. The other piece of advice I would say, line yourself up a couple different tiers of mentors. What do I mean by this? I would say top tier mentor are those folks, your senior surgeons, Dr. Elliott, Dr. Wessels, Dr. Vani, where you can really bounce high order things off, well-formulated questions, thinking about a problem in complex ways. And then you're going to need your mid-career mentor, where you're asking, hey, which approach would you do here? Could you look at this rug? What suture do you like to use? Things like that. And then you're going to want to pick your peer who you ask very dumb questions to. And you're going to want to have, and I won't give examples of those for fear of judgment on this podcast, but that has been extraordinarily helpful to me. Somebody you ask higher order things, some people you ask most things, and some people those are the secret questions that you don't ask anyone else, but you need one of each for sure.
No, I think that is great advice, and I'm now thinking back on who each one of them is for me, and I think I've got kind of one in each, but I hadn't really thought about that categorization. It's absolutely true.
Yeah.
And then the only other one that I would add is the chief resident, who you're like, how do I get to this room again?
Yes, the logistical chief resident is very helpful. Yes. Yeah. And then it's fun. Now I find myself being the dumb question gal for other people, and that's great.
100%. No, I've had similar, not bouts of anxiety, but these twinges of that case went well, but what if it didn't, I have found myself a couple of times, post cystectomy, getting like KUBs in the PACU to make sure the stents are where I put them.
Yeah.
And that is not something that my mentors did in fellowship. That's not something my mentors did in residency. But in your first year of practice, you can't go to bed because you're like, what if that stent wasn't where it should have been? And trying to figure out what KUBs are okay and what KUBs I need to like learn to let go,
Yeah.
I think are important. And it's, I mean, we're still learning it, but trying to figure out what I need to be able to sleep at night and what I need to be able to be confident in that the case went the way that I expected it to has been a big learning point for this year.
Yeah, for sure. And it gets better. In year 2, it's gotten better, but it's still there.
Absolutely.
I mean, if I have a patient in-house, if I wake up in the middle of the night, I'm checking their vitals.
Yeah. I mean, see if they got any labs recently,
Yeah, I'm making sure they're not in the ICU. Like, I still do that. So, I mean, it's normal. Give yourself grace. Have a lot of people to turn to and ask questions or even just vent. Even people who had shared experiences. Hey, I had this complication. Have you ever had that? And I bet you'd be surprised to find out that people have gone through similar stuff. Yeah.
Yeah. I was at my annual review this year, I was talking to my chair, Cheryl Lee, and I was kind of explaining some of these anxieties. And she was like, that just means you're not a sociopath.
Yeah.
Like you're doing surgery on people. Like those are normal things to worry about. I was like, okay, I guess that makes me feel a little bit better.
And I would just say, another good piece of advice, especially if you're trying to build your practice, like the same advice I gave for fellowship, to be available, I think is so important. Make people, people should know your name. People should know that they can call you for anything. Your partners who are non-reconstructive, should know that they can rely on you to see people. Even if a partner of yours asks you to see something and it's not in your wheelhouse, see them.
Yeah, absolutely.
Yeah. I mean, I can't stress that enough. And this goes without saying, but be really nice to the people in your ORs. Be nice to your nurses, get to know their names. That goes a really long way. You build that reputation from day one, if you're somebody that people want to work with or not. And that's honestly been a huge referral builder for me, because everybody who works in the OR, I mean, they all have family and friends with urologic issues too. And their eyes and ears are open and they have their favorites and everybody talks and just be kind to all those people, goes without saying.
Yeah, I think kind of both literally for the, your fellow surgeons and doctors and maybe metaphorically for the people in the OR, if you want to be the person that people call, they kind of got to have your number already, I think is maybe a way to think about it.
I still don't give my number to patients, but
yeah. Once as an intern, and man, I'm gonna try really hard not to do it again. But you learn that lesson hard.
The hard way.
Any last words, folks interested in the past, present, or future of reconstructive urology?
I think this is pretty comprehensive. This is a lot of fun. Yeah, if anyone has additional questions, I mean, I'm very reachable. You can look me up and shoot me a little email.
And you do same day visits.
And I just same day. That's right.
Yeah.
Yeah. But yeah, I think this has been great. Thank you so much for having me, and wish you the best. I'm glad to see that you're doing so well. Congratulations on your early career too.
Thank you. Yeah, no, I think it's been going well. I think hopefully it continues how it's going. It sounds like we're both doing okay for now.
Yeah, for sure. Yeah. And I never regret this field. Super happy.
No.
I mean, even with all this anxiety, it's so worth it. I've never questioned if this was something I was meant to do or not. It definitely is, without question. I could just see it getting better and better.
Yeah, 100%. Absolutely. Thank you again so much for joining me on BackTable Urology, Dr. Mann. It's always so wonderful to talk to you about reconstructive urology, and your energy, for the field, I think really, really shines through. So I really appreciate you taking that time to talk with us.
Cool. Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.